Good afternoon and welcome to November's episode of Inspire Ask the Expert. Today's topic is going to be lung ultrasound, point of care lung ultrasound. Before we get started, everybody should go ahead and introduce themselves. Tom?
Yeah, my name is Tom Pereno. I'm a respiratory therapist in Canada.
My name's Keith Lamb. I'm a respiratory therapist in Virginia.
John Encrop, flight respiratory therapist, Advent Health, Orlando, Florida.
Andy?
Good afternoon. Andy Klein, respiratory therapist in Chicago, Illinois.
Eric and Khalid?
Good afternoon. Eric Kreiner, respiratory therapist out of Washington, D.C.
Hello, everyone. My name is Khalid Al-Wadi. I'm the Director of Respiratory Therapy Program at King Saud University in Riyadh, Saudi Arabia.
Dr. Scott?
Hi, everybody. My name is Brady Scott. I'm a respiratory therapist and professor and program director in Chicago.
Carson?
And my name is Karsten Roberts, respiratory therapist in Philadelphia. I'm a director of clinical education.
Sarah?
Sarah Vazalik. I am a respiratory therapist. I'm at Frederick Health, and that's in Milwaukee, Wisconsin.
Welcome on. Madison, I think, is signed in the general, and she's in general population.
She's in Gen Pop.
She's in Gen Pop. All right. So Tom will go ahead and get us started with the slide deck.
Yeah, so I've put together some slides because the issue with lung ultrasound is we can talk about it all we want, but it's a very visual thing, obviously, because it's a way of visualizing the lungs and dynamic processes, etc. And although it's not, I would say, traditionally an RT role for bedside lung ultrasound, it's definitely growing in the literature. There's papers that have discussed the process for learning and retaining that knowledge. And I believe it's a growing field. I asked the comment or the chat box that if anybody works in a hospital that RTs do routine point of care ultrasound for lung ultrasound in specific, but if you do other types of ultrasound, let us know where you work, sort of give a shout out, because that's pretty exciting stuff. My previous workplace, we did diaphragm thickening fractions for ultrasound. So we did diaphragm ultrasound, but we did not do lung ultrasound. The RTs weren't doing it at the time that I left, but I am not sure if they were looking into that. So I'll quickly talk about lung ultrasound and sort of what are common and popular, not so much measurements, but visualization tools and terms that are used when doing it. And of course, by doing that, we'll discuss what can be done with it. I'll talk about some protocols and some sort of decision trees that exist in the literature. And I will, after I go through these slides and we're discussing things, I'll probably start posting some of the links to some of the papers like I normally do. First off is probe selection. There's obviously a number of ultrasound probes. If you've ever seen an ultrasound machine in your intensive care unit, there's probably at least 2 or 3 probes sort of sitting attached to it. Depending on what you're looking for might determine which probe you're looking for. When I spoke to a colleague of mine yesterday, he said his go-to if he is considering assessing for a pneumothorax, or there's a suspected pneumothorax, he's going right for a linear probe. It has a higher frequency range. Otherwise, for regular routine ultrasound, he'll use a lower frequency probe. If he has a microconvex, he'll use that. Otherwise, use a curved linear. And like I said, the linear one is the one he's using for diagnosing pneumothorax. In terms of where you assess the patient's lungs, you separate the lung into the fields that are shown here, where you have a superior and inferior. And you have right in the front, and you have lateral, and then you've got sort of the posterior area of the lungs. Now, you're not flipping patients onto their back or anything. It's basically as low as you can reach into the posterior area. And when you do that, the visual things that you're looking for, the one in the top is, these are in the top left corner, because I don't think you can see my cursor when I'm going over these slides, so I'm just going to say visually. The top left one is considered an A line. I'll actually walk through these. B are coalescing B line, or not coalescing, but B lines that are well separated. C is more coalescing, so there's like larger grouping of these B lines, which are sort of vertical light rays that sort of shine down. And there's a better description on the next slide. And then the final one is collapse and consolidation, and a pleural effusion, which is the large dark area. But I'll show bigger pictures of this. So this is A. This is just a normal patient. Just a normal pattern, I should say. The pleural line, or the white arrow, can be seen with multiple horizontal A lines, and this is actually an artifact. So you see the reflection of the lung sliding area, or the pleural line, that is just sort of reflected later on, and it's an artifact, but it indicates that the lung is full of air. There is nothing there causing an issue with that image. The B lines I mentioned, so the pleural line is visible. That's what the white arrow is pointing at, and you can see it's sort of hyperchoic, which just means it's brighter. And then there are separated B lines. So each of the asterisk symbols show you this B line, and they just look like ray of sunlight coming down from that top line. And you can see how they're distributed. So this pattern corresponds to moderate lung aeration, or some loss resulting from an interstitial process. Then you get, again, here you have that pleural line is still visible. You can see with the white line at the top. And then the two dots are showing the coalescent B lines that are in between those two dots. So it's similar to the rays we saw before, but it's a much thicker ray coming down that you can see. And then the pleural line and spreading up to the edge of the screen. So this pattern corresponds to severe lung aeration loss resulting from partial filling of alveolar spaces and pulmonary edema. And then D, so this image here, basically you have a consolidated lower lobe. So the lower lobe starts to look like a chunk of tissue. So the lung has a tissue-like echo texture, it's called, and that's where the letter L is. You can see it's like this little bulk of tissue there. And then the hyperchoic images are just sort of bright spots, and those can be seen, those correlate with consolidated areas. And then you see this large dark area where if you see the words PE, that's sort of where it starts, but it comes around, and you can see that this is just pleural effusion. So there's nothing there to see. There's no tissue or lung tissue is just solid black. And then in terms of what you do when you analyze each one of these areas, there's something that's called a lung ultrasound score. And essentially the worst possible score is the highest score you can get, and the best possible score is 0. So each area, if you were to see those A lines across all fields, you get a 0. But essentially what you're going to have is perhaps a 0 in one area, and then you'll have some well separated or coalescent B lines. And of course, once you get down to the posterior areas where you're more likely to see consolidated areas. But when you add up this score, what's the purpose of adding up the score? Well, when you have this score, you can then begin what's called lung monitoring with this tool, where then the following day you could redo the process and see if the score changes, or even better, doing PEEP titration. So much of these papers discuss the response or the re-aeration when you compare two PEEP levels. And in fact, in this study, they compared like a PEEP of 0 with a PEEP of 15. And then they have differences of scores. So if you have a re-aeration, so if you go from a score 2, which is the coalescent B lines, if you were to improve to just separated B lines, that would be +1. Or if you went from a score 1 to a score 0, that's a +1. If you went straight from coalescent B lines, which is the score 2 category, all the way to A lines, then you get a +3, etc. So you can sort of alter the score or get a re-aeration score, which will demonstrate that you have an improvement in response to PEEP. One other thing, this is, again, looking for a pneumothorax it's actually quite interesting and cool when you see it at the bedside. I have been at the bedside when we've looked at pneumothoraces, and we did do this in our cadaver lab as well. But at the top, you have a normal image. A is what the normal ultrasound looks like. Again, with those A lines, you can see they're just reflective hyperchoic patterns that go deep. And then to the right of it is something called M mode. So it's just a mode change on the ultrasound machine. It's a button that you literally just click M mode. And what it does is it's taking a single time point, and it's just that single time point over time. And what's normal is something that this is called the seashore line, where it looks like you have sand and water. So that line, this is a normal image. The one below it You may not see lung sliding. So if you see lung sliding, that's what you'll see at the top, the image A. Below it is image B. And if you don't see sliding, you might just see what almost looks like a barcode pattern. But if you see interruptions in those lines, and you'll see that they've actually put the ECG tracing below it, this is called the lung pulse or the pulse sign. So if you see that, it doesn't indicate that there's a pneumothorax. It could just be that the lung is not sliding there, and then you're seeing this reflection or this artifact of the cardiac pulse. And then on the top right is what you would see if you had a pneumothorax. Well, not necessarily pneumothorax, but you see no lung sliding. And again, you get that barcode image, but you'll notice there's an absence of that lung pulse. So there's not lines of lung pulse. And then at the very bottom, D, this is called the lung point. So if you see no sliding in M mode and you see that pattern that just looks like a bunch of lines, like a barcode, as you move down the lung, you're going to see a point at which you have lung tissue and where you don't have lung tissue. And that's called the lung point. And as you can see, it's a combination of that seashore line and then just the straight lines, which the name is escaping me at the moment. And then this is how some protocols, I asked my friend and colleague, who he's actually on the next slide here, Alberto Goffi is the first author here. He's the one I talked to yesterday. And he sent me this paper and said, this is really sort of the go-to standard. It's going to seem a little bit complicated and busy, but essentially, you start with the anterior fields. If you see A lines, if you don't see sliding, then you're going to assess for pneumothorax. If you see sliding, great. And essentially you follow down the tree. I won't go through all of this. I'm going to share this paper instead. I'll share a link to this paper. If you see B lines, then you decide, are they focal or diffuse? And then of course, if you see consolidations in the anterior fields, this is probably more rare, but this would describe a very heterogeneous process if you saw it in the anterior fields. But essentially you assess the anterior fields first, and then you move down to the posterior lateral fields or other point of care ultrasound techniques. And then finally, this is the paper that he wrote, which is essentially this diagram here is how to quickly assess for a pneumothorax only. So I think, in all honesty, if I were to consider the ideal thing for an RT to have access to lung ultrasound in the ICU would be that patient that's getting extremely complicated and you feel like you have a sense or a feeling that perhaps this is a pneumothorax, and rather than ordering chest x-ray and waiting for a portable chest x-ray to come, and of course you have radiation associated with that, a quick lung ultrasound, if you get skilled enough at this technique, you can quickly determine it. So essentially, you're lying the patient in their proper position. You're choosing the proper probe. Again, higher frequency probes will be your first choice if you're assessing for a pneumothorax, and then you're going to acquire the image. And essentially, for the image interpretation, you're looking for lung sliding. If there's lung sliding, yes, great. Is there lung pulse? Yeah. So if there's no sliding and you see lung pulse, yes. Great, it's probably not a pneumothorax. You can see how it's going, how the decision tree on the bottom right is just sort of leaning to yes, yes, and no pneumothorax. But let's say you don't see lung sliding, you don't see a lung pulse, vertical artifacts are identified. So again, you've already looked at the M mode, and the answer is no. So it's likely. And then if you identify that lung point, which if you recall looks like B down here, the M mode where you have the seashore line followed, and then right beside it is the, again, and you'll see movement of this in M mode. If you see that, then pneumothorax is highly likely. And this, if you are looking at ultrasound sort of protocols, this is the one that I was first, my attention was brought to first, which is called the Blue protocol. And again, it was mostly for assessing quickly, like, in the emergency department, you're looking for lung sliding. If it's present, are there B or A profiles? So if it's B, you've got pulmonary edema. If you see lung sliding and you have A, B, or C profile, it's more likely pneumonia. And then, of course, all of these decision trees bring you down to whether or not you think there might be pneumonia or COPD. Now, this is where it gets complicated because RTs are not intended to diagnose certain conditions, at least in Canada. It's outside of our scope to actually portray a diagnosis. So we can find all the signs and create a report, but then in terms of like diagnosing something, this would obviously require the team's input. And then I'll just put these two talks or these two papers up here. And again, while you guys are discussing everything I'm saying, and sorry, I'm going through the visual stuff. I'll let you guys all sort of take over in a moment, and I'll start getting the links for all these. But there's a few papers out there that have looked at training respiratory therapists to perform these tasks, and sort of not only how the training was done. Essentially, they have to do 10 ultrasounds on their own that are then their results are validated by an expert. And then some of these studies have looked at retention. So they then test the RTs later on to see if they can still recognize and sort of retain that knowledge that they learned during the course. Similar to some of the papers on recognizing asynchrony, for example, that I know Eric has been a part of. All right, I'm going to be quiet now and collect some stuff for you.
Thanks, Tom. That was good. For the educators on the panel, how many of you have some POCUS in your curriculum? And what do you talk about?
I guess that means me, at least one of us. I know Carson is an educator as well, but we actually do have some coverage of ultrasound in some of our cardiopulmonary diagnostics material. At this point in time, it is not part of our normal, critical care checkoffs and labs and things where students have to perform independently, those type of things. But we are certainly talking about it in terms of imaging in the ICU and critical in other environments.
And for us, the same is true in terms of teaching radiology back in Saudi Arabia. So it's part of it. It's like being introduced to the image, chest X-ray, the technical aspects of the film itself, and the diagnosis part of it. So, but not really into details in terms of the ultrasound.
Yeah, and I'm not using it at all to teach. I'm teaching my critical care class right now, in fact, and I don't include lung ultrasound at this point, just because respiratory therapists largely aren't doing it on a regular basis. So I am aware of a few respiratory therapy programs around the country that have spent Perkins grant money to purchase lung ultrasound equipment so that they can train the respiratory therapists and do competency checkoffs. But to me, I feel like that's a waste of valuable time when we're not actually testing the students on lung ultrasound at this point. I would rather get them to a higher baseline of competency on the things that they need to do to be successful in their early careers, than to teach them something that is really, easy to teach and easy to, like the couple of studies that Tom put up there, are respiratory therapists do pretty well with practice. But again, this is something that's probably being done by people that have experience, are high performers, so to speak, clinically.
So I see that Keith, that Tyler Weiss just came in on the call. So Tyler, as everybody, he can introduce himself, but Tyler in our group has all the experience with ultrasound, so he can speak to that about kind of how that's evolving. That's his class he teaches, but he also is involved in some research on it at the bedside.
Yeah, so I incorporate lung ultrasound into I'm Tyler Weiss, by the way. I'm the director of clinical education at Rush. My whole PhD dissertation revolved around lung ultrasound. So I have ultrasounded quite a lot. I'm trying to block it out of my brain.
Were my slides acceptable, Tyler?
Your slides were actually given a talk on lung ultrasound at ARC, and a lot of the studies that you have are in it's almost like.
Okay, perfect. I mean, I tried to keep it simple and straight to the point, but it's great to have someone who actually educates on it to say they were okay.
Yeah, no, it was really good. But yeah, so in my class, cardiopulmonary diagnostics, I started incorporating lung ultrasound into that course to try to just introduce to the students this tool that is at every ICU has an ultrasound in it. So why not have the RTs grab it and maybe make some of these assessments patient, or even just looking at assessments. How I sell it to RTs is, all right, you're doing bronchial hygiene all day, and you're not convinced that this is something that needs to be bronchial hygienated, if you will. And you put a probe on, and you see it's just a massive effusion. And you can now take that to the team, like, hey, like, you ordered bronchial hygiene here. This is just a large effusion. And then that sort of perks people's ears up. But it's a really quick, easy tool, I think, to utilize at the bedside. So yeah, utilize it in the program to get students aware, and then doing research at the bedside, teaching RTs how to actually incorporate it. So I'm going bedside with the RTs and seeing how long it takes for them to become competent.
So I'm doing a shock lecture at ARC, and one of the things that I do bring up is point of care ultrasound for patients that might have collapsing IVCs. When you look at the amount of shock or how insulting the shock is, that you can look at that. And if you do, it's pipes and pump basically, right? So heart and your vasculature. And if you do have a collapsing IVC on inhalation, then you probably have lack of fluid. And so we fluid challenge those patients before we start them on pressors. Obviously, we want to tank up the pump. So that, and we use it for arterial access. Certainly, if we have a patient who is clamped down peripherally, you can look at your landmarks with a point of care ultrasound. It's very handy. So we just purchased 4. We have one for each aircraft and a backup, and one for our intensive care unit truck that we use on the ground. So it is starting to take hold with our team. Being an interfacility transport program, we don't see trauma. We don't see all the blood and guts. So we really don't use it a lot in the air because most of our patients that we pick up are coming from other facilities, and they've hopefully been stabilized. But nonetheless, it is gaining traction. It is very useful. And I think we'll see more of it on my team and certainly in the ICUs.
For those that are in the chat, how many of you, and even for the panelists, how many of you have used it for arterial line placement, to facilitate with arterial line placement? And I have as well. We did a study of over 40 patients, and after the first 5, most of the volunteers for the study were university students that would come hungover and like just dehydrated, hungover, and I'm like, I can't feel anything on your arm. So I got sort of trained in the process. I actually called one of my intensivist friends to come with me to see a patient once, because I was explaining to her my difficulties. She's like, why aren't you using ultrasound? I'm like, no one showed me how to use it. So she came and showed me, and then she watched me do 2 more, I think. And then I was off to the races. I probably should have done more to be more confident, but once you do, and maybe John, you can agree, or anyone else that has done it, once you've put an art line in with an ultrasound, you kind of don't want to do it without. Like it makes it so, I don't know, for me anyways, it made it so simple, so easy. It just changed everything, and it made it so efficient, so fast. There was no messing around. There was no redirecting. It was like just slight redirecting, but you can visually see yourself redirecting. It was phenomenal.
I think it's hard sometimes, as we all know, because we're veterans, but it's hard sometimes to change the mind of some people that have always done it by palpation. And they've always, I know all my landmarks. These are the same guys that don't want to give up direct laryngoscopy for video laryngoscopy because they're so old school. But at the same time, this is about your patient, and you won't want to sit there and cowboy your catheter 3 or 4 times trying to puncture this artery when you have ultrasound that's available, and you can probably get it on the first try. So
I'll say I early in my career when placing art lines, not every facility that I've worked in has a respiratory therapist been art line, but that's how we were trained earlier in my career. But I never really got good at using ultrasound for finding the arteries. I had a physician a few years ago that would always grab it, even to do a radial stick. And I guess I get put in the category of old school. I've been an RT for 18 years, but maybe I guess, I don't know.
You're still a baby. You're still a baby.
I know. I knew you were going to say something, Keith. But but I just like, we got trained to do it by palpation, right? So like I still teach my students how to palpate a pulse when we're doing, we just did the lab. My students were competency checked off last week on arterial sticks. And he brought the ultrasound to the bedside and said, here, practice with this, see if it helps. And I couldn't do it. I found it really challenging. And maybe it goes to like some of the articles, like I said, that you publish it. Now, those we're talking about lung ultrasound, we're talking about arterial punctures now, or arterial lines, but it's just getting that practice. And I tell my students, you have to learn how to be ambidextrous. So that's part of that practice of switching it up and trying to do something slightly different. I don't know, what would a art line look like if you're using it on a art line puncture, like on a mannequin? Would you be able to look and see like the cannulas that go through the arms to be able to see? Tyler, have you ever done that?
I have, and no, not, you don't, it does not look.
You can't see it. It
No.
doesn't look like yeah.
They-
So
they
it's just
have-
it's practice on patients, right?
Yeah, or the first thing, as you said, it's like it's repetition. You got to keep doing it, because what I have even been finding teaching lung ultrasound bedside is I'll take a RT bedside, they'll do ultrasound. By the third patient, they have it down pretty good at acquiring the images. Diagnosing with the scoring, it's got some work to do. But then it might be a week later or 2 weeks later, I go back with that same therapist. It's like starting over again if they didn't do it. So same thing with the vascular. So I always tell students, or even our teachers, just practice on yourself, like not poking, but just finding the artery. Just find the artery, and then get practice at the holding the probe and acquiring the image. Then you can go on to the next step.
Yeah, landmarking is one of the coolest things when you pull an RT aside and you're like, hey, check this out, and you just like landmark yourself. Yeah. Or landmark them, and they visually see. It's like, wow, that I can see the vessel very clearly. But I will admit that using it for vascular access it's a little bit more tedious to learn because of the sterile field. Learning lung ultrasound is a lot less of a complexity. Not less complex in terms of what you're monitoring and all of the different areas, but you're not worried about the sterile field in the same way. So you can easily mess up vascular access ultrasound for an art line by accidentally placing it in the wrong spot. There are huge, obviously, like big socks that essentially go over, like just plastic bags that go over the probe so that you can keep it sterile. They're sterile bags. But the minute you put that in the wrong spot around your field, you could possibly sort of mess it up, and then you're calling for someone else's help to come in and help you out with, recreating that sterile field with the ultrasound probe.
Yeah, the use of ultrasound to place A lines is definitely a game changer. I haven't done it that many times, but I sort of look at it like laryngoscopy, like John said. The CMAC and the glide scope and the McGrath, all those things have really been game changers with intubation. That being said, you're going to find yourself without one of those things at some point in time.
Yeah.
And so you don't want to forget or be completely out of practice, either using your landmarks for the A line or the or direct laryngoscopy. Yeah,
it got to the point where if I was palpating for an arterial line and I had trouble determining exactly where it was or the direction, if I wasn't confident, then I would just grab the ultrasound. Because otherwise, if I can feel a great pulse, I'm like you guys. If if you're old school, you can get it because if that's how you were taught to do it. But after using the ultrasound for difficult to palpate vessels, my brain just immediately goes to grabbing the ultrasound. Because like you said, it's a game changer for those difficult to palpate, because then you don't have to worry. You can visually see it without any issue. Normally, I haven't had an issue visualizing a vessel.
So I wanted to pose. Oh, sorry, Kurt. I was just going to say I wanted to pose a question to the panel. So my current role is respiratory practice specialist, and we don't currently do lung ultrasound or even do art line ultrasound. I'm curious what your thoughts are on how organizations could start moving towards having this, because I certainly like the idea of implementing it, getting our staff highly involved and doing, a more closer assessment to the patient. So how would you propose that as somebody trying to do clinical change and practice standards, get that implemented in their organization?
Have a physician champion.
Yeah.
Before the pandemic, we were working on getting respiratory therapists to do lung ultrasound. So I started, at the time I was adjunct faculty at Boise State, and I was teaching critical care. And I was actually teaching the 2016 article that Tom put up. I was teaching that as a part of our curriculum at Boise State, and even some of the other slides that you use to describe the decision tree and everything. But I got interested in it from my adjunct position, and then we had a physician champion that actually approached us and said, hey, I feel that respiratory therapists should be doing more of this. And one of the things that these articles point out is that the respiratory therapist can actually improve ICU services and add to the tools that we have available at the bedside without overburdening the physician. And so that's part of his interest in that. And having the RTs. But then, of course, we know that the pandemic changed everything, and we were never able to put it into practice. But again, if the tables had been turned and it was the respiratory therapy, the department that came to the assistant program director of the pulmonology group and said, hey, we want to do lung ultrasound, he probably would have been like, what are you talking about? But it was him that came to us. And so I think that's why a physician champion is the most important aspect of it.
I'll add this, Carson. I think, because I'm in a similar, I think probably in a similar role as Sarah, in practice and policy, implementation, education, all the aspects of it, right? And so as I've been sitting here and kind of listening, Sarah, I think what I got to was like, what's your why? Like identifying that, right? I mean, so I in full agreement that, the implementation of something like this, regardless of what it is, whether it's esophageal manometry or EIT or any of these kind of advanced monitoring techniques, you got to have the champion for it, right? You have to have the underlying pinning of a support model. But there's got to be, I feel like, I'm asked this a lot, like, why do you want to do this? Like what is your endpoint? Where are you gonna get to, right? Like, do you want to do lung ultrasound? Is your why because it's cool? Or is your why because I am going to influence and change practice in this way, right? And I think, if you're able to identify that, I am going to build it into an airway clearance bronchial hygiene protocol, right? And say, for efficiency standards, and say, I'm going to do this modality and have a before and after, and be able to say, yes, I'm meeting clinical goals and outcomes with this, right? I mean, I think then you're kind of talking about something, or going further, PEEP titration, whether, your institution can't afford an EIT because they're just so wicked expensive right now, and you have lung ultrasound and you are modeling PEEP titration type of thing, right? And using that as a surrogate. I think that's kind of the important thing, and what I've been kind of rolling around in my head, just kind of listening to this, like, because I'm like, do I want to do this? How would I do it? And I am anticipating the conversations that I would have, which is like, my guy is he asks me this all the time. What's your why? Like, why do you want to do this? So I think there, and I would clearly at that point, I don't have that answer. I would beg like each one of you guys, like, hey, help me figure out my why. Like, where am I going to get to, and how do I fold this into a surrogate for success of therapy or a determination of ineffectiveness, right? And I think then you're kind of talking about something as opposed to some abstract nebulous diagnostic tool, right?
Yeah, and I want to highlight that physician championship because that's absolutely key. And what you'll find interesting is that if you look for it, you're going to find a physician who's already sold on POCUS. Like there's like that person probably exists in your organization who they are all in on point of care ultrasound, whether it be for line placement, whether it be for lung ultrasound, for assessing consolidation PEs, whatever. That person probably exists because I would say the hype for POCUS definitely started from the physician side and is trickling down into the RT side. And it's a lot of that trickling down is because of these key stakeholders, these physician champions that are so excited that they just want more people able to perform some of these tasks when they're not around, or for efficiency, as Eric was saying, for efficiency of procedures you already have. So definitely look for those in your institution and see what they're using it mostly for. Again, and you might find different champions. You may find champions that use it for every single line placement they use. And so if your RTs put in routine arterial lines, the process might be, if you have difficulty palpating, and again, this comes to Eric saying something about protocols, you could write in the protocol that if you're having difficulty with locating or properly assessing the vessel, then consider the use of ultrasound. But of course, a training program needs to be instituted. How many art lines do you expect them to put in while using ultrasound? And it should be under guidance, someone who is experienced sort of doing that. So we rolled diaphragm thickening fraction ultrasounds out at St. Michael's Hospital when I was there. And it started off with a physician champion. Well, first the how, to bring back to Eric's point, or sorry, the why. Let me clarify. The why was Ewan Gallagher was publishing papers on diaphragm thickening fraction and its association with mechanical ventilation, time on the ventilator, excessive work, etc. And so we had physicians starting to ask for diaphragm ultrasound, and they were calling radiology, and they were coming and doing diaphragm excursion measurements on patients that were on the ventilator. And just so you know, you don't do excursion measurements when someone's on a ventilator, because the ventilator pushes the diaphragm, so it doesn't tell you what they're doing. You have to take them off the ventilator or put them on a T-piece or take away all support in order for you to get an accurate excursion profile. So they were basically ordering the wrong test. So we pointed out, no, you want the thickening fraction, don't you? Like from Ewan's papers? And they said yes. And I said, okay. So then we got Alberto Golfi to teach 3 of us as sort of super users how to do it. We each did 10 each. They were validated by Alberto. And then when we went from there, then it was like, okay, now you are trained. Now you become the trainer. So then we would go through and start training the bedside staff. But again, it came down to the why. Physicians were ordering it and they wanted it. And then the how came down to, okay, physician champion, check. We had that. We did proper training. We had 10 measurements. But again, all of this went on before we even told the RTs we're going to do it. Because if you start telling them, some might want to get excited and want to do it. But essentially, we waited till we're fully trained. We're like, okay, we're going to now teach you guys how to do this therapy. Here's a few education sessions. And then you go to the bedside and you start doing it.
I think, to summarize something that several people have said to Sarah, I think as an educator who is responsible for, I would be the one responsible for essentially rolling this out at my hospital. And we've had this discussion with things not related to ultrasound, but just other things that we've thought about rolling out. I think the thing that needs to be figured out first is, how many of these are you going to do? Can people stay competent, even if you just have a core group, right? Because I can teach somebody how to do something, and like Tyler said, while they're standing there doing it, they are literal experts. And then 5 days later, they're like, man, where was I supposed to put that thing? And what did those lines mean? And so if you're not doing enough to continually cement that in your brain and stay competent, then it becomes I think a little bit more of a moot point, because if they're going to call for it once a month, even if you pick 5 people on your staff to be very strong and competent at that, if they're only doing, getting called once a month to do the procedure, then they're going to forget in between times of doing it, I think. And so we ask that question a lot when it's like, even if we have a why, Eric, like we have a why, hey, this makes a lot of sense, I think this is something our staff could handle, X, Y, and Z. But then it's like, well, wait a minute though, like what's our actual volume? How many vent patients do we actually have that we struggle with getting the right amount of PEEP, that we would use EIT, or that we would use, ultrasound for that. And if that number is very small, or we anticipate it to be very small, then it becomes a question of, are we putting them in a bad position by training them and offering this therapy? Because then the therapist who's on, that's supposed to know how to do it, then gets put in an awkward situation because they don't remember how to do it, or they forget something, or they do it incorrectly when it matters. And then, then your department sort of looks, has a little egg on their face, so to speak. So I think there's a lot of moving parts there in terms of a training and a rollout. And I think Eric asked a good question, which is, what's the why? And then once you determine, hey, this is a good reason and this is something we should do, now do we do enough of them to make it make sense to have people do it and to put them in a good position to succeed as well?
So let me ask Sarah a question then. Like, so what is your why? And like, could you, like, if you, based on everything that we've talked about so far, why would you make a pitch to your physician group to have respiratory therapists in your institution get trained on lung ultrasound?
Well, I think you guys actually hit it on the head. For us, it is PEEP titration as one of our biggest opportunities. And then we've actually had some discussion with some of our providers that actually would love to see our team performing these, specifically for identifying earlier for risk of pneumothorax. Like you were saying, Tyler, too, like pleural effusions versus actual secretion management issues. So there's a lot of opportunities, I think. So we have the why, but the other thing that's sticking out with kind of what you were saying, Andy, is the how. And really, do we even have the resources in place to allow for this time to happen? Because that obviously is going to take an RT away from other tasks, whether they're indicated or not. So I think trying to figure that out, thinking from a practice side of things, how do we make this that it would be viable for our RTs long term? So yeah, I'm in the same boat as you, Eric, where I'm trying to think like, how could we make this sustainable? And then also, I am not the content expert on it right now. So how do I help with getting those right resources or becoming that expert?
That's a great point, Sarah. I didn't even touch on the workflow piece of it. Anytime you roll something new out, that's got to be part of it, right? I mean, every RT on this call, I'm sure, has had workflow limitations to things that they really wanted to do. And, who's going to cover that person's area while they're in a room for an hour, doing, getting, measurements and making vent changes and all those different things. So yeah, that for sure has to be part of the thought as well.
Yeah, I think that's been one of the barriers is when I'm teaching the staff bedside, they're like, oh, this takes a while. But I will say after doing thousands during COVID, I was doing during COVID with prone positioning, and Andy helped me out. So I taught Andy pretty quick to get the images. I didn't really teach him to interpret them because I just needed images, at 3 a.m, so I didn't have to come in overnight. So, teaching, and I think, Andy, you can probably speak to it too. After you did a few of them of the 12-point assessment, you could get them fairly quick. You weren't taking, forever. So, I mean, I can do probably a 12-point ultrasound in under 10 minutes now. Some people a little bit longer. But then, again, if you're implementing therapies and then, doing a reassessment, which to Eric's point, I see that as a huge why. Is I'm doing this therapy. Are we actually getting the response we want? So maybe assessing pre and post therapy with lung ultrasound. But yeah, it's a whole nother aspect of care that the RT has to provide. Then you have to think about ultrasound machines because everyone is using them, and it's like, okay, do you need to buy your own? They're not cheap. You can get cheap ones though. So then it's just understanding which ones do you want. Is the image quality. There are some now that have AI. I just looked at one on Friday that have AI to help interpret things a little bit easier, which is nice. But there is a little bit of a learning curve, and it does take time at the beginning. But I think, again, with repetition, the more and more you do it, so that you get pretty quick at it.
Yeah, I think so. I agree with all you guys, and part of the why is there's got to be a need, right? And so, again, like I think it was Eric, or I can't remember who said this, but it can't be something that's just cool, because it is cool, but it needs to coincide with a need. And if you think about, I think that maybe the natural transition, the natural evolution of the use of POCUS for whatever. A good example of that is with the folks who get IV access in your hospital, right? If you think about we have a team that gets PICC lines, that places PICC lines, and they roll around with their ultrasound machine. There was a day where nobody ever used a PICC line or an ultrasound machine to place a PICC line. But the need is, hey, listen, these things can be difficult to get sometimes. They can certainly be painful for the patient. And so, and if PICC lines sort of gained a lot of popularity a few years ago. And I think that it was just a natural evolution. And so for the RT, I think it makes sense to me that the natural evolution would be, okay, well, if you're going to place A lines, or even if I've used ultrasound just to get a sample, not even place a line, but to just get a sample. I think it was, I can't remember who it was, Jacob mentioned the use of pin Dopplers that are commonly at the bedside to use for pedal pulses. Those are fairly, I've been fooled by those things on multiple occasions. I'm like, oh, there it is. Oh, there it wasn't. But ultrasound obviously is a good progression in that realm. Some of you guys talked about, so outside of the use of ultrasound for parenchymal abnormalities or pleural abnormalities, like you guys have sort of talked about, a couple of you mentioned the use for diaphragm measurement, right? And I know that we have been involved in a study recently that looked at diaphragm thickening for looking at it to evaluate for liberation from the ventilator. And, there's a lot of data, and all of you are familiar with this now, but a lot of data that talks about under support versus over support and the detriment that either one of those has on the diaphragm. So getting outside the parenchymal, the pleural disease utility for ultrasound. Eric, do you have anything to elaborate on in terms of the use of ultrasound for diaphragm evaluation?
Well, I think Tom is going to take the floor on this. Yeah, for sure. But it is, it is of interest to me for sure, because I think what we use as a surrogate for that over versus under assistance is our waveform analysis, right? And that is, whether that is a great surrogate or a poor surrogate, for its clinical outcome, I think is the question. And then how can we reliably do it? Monitor these waveforms. Is everybody as good at it? Is everyone else? And all of that is wrapped up in there, right? But to understand over versus under assistance beyond the measures that everybody has, which is waveform analysis, you could argue P01, but you then kind of run out of rope really soon, right there almost, right? Because everything else for over versus under assistance is, kind of advanced, right? Is change in esophageal pressure and those dynamic measurements and whether you're measuring ED signals, and now you're talking about focus of the diaphragm. What is of value? That would be my question. Just of like, where do I concentrate my forces to say, look, I'm trying to thread this needle, and I have what I think is fairly crude measurements in the form of waveform diagnostics to understand whether I'm over versus under assisting them, and where am I going to get the real truth, essentially, right? Tracing it back to its inception, and whether that's diaphragm thickening or not, I think is, from the literature, it's Ewan's, all of those papers coming out of your guys' group, Tom, is what I put down in front of everybody, right? That say, look, from my vantage point, we kind of got three options here. I got two catheters and I got a POCUS. And which one do you want? Which one do you want for us to understand whether we're under or over assisting these guys, right? And so, kind of therein lies where I am. That's my crossroads exactly today from a clinical design practice design, right? And where I'm going. And I'll just be honest, I kind of got all three on the table. The two catheters were already in place for other reasons. But I could easily be talked into this diaphragm thickening practice, right?
Yeah, I can give a good example. We actually had a patient that they inserted a NAVA catheter in because they wanted to use NAVA, and there was no EDI signal. And before I got called to the bedside, they had actually pulled the catheter out, thinking the catheter was broken, and placed a second catheter. And like they're not cheap catheters. And so anyways, they placed the second catheter, and the same issue, they could not get an EDI signal. Now, this patient was clearly breathing. You could see the accessory muscle use, but there was no EDI signal. So we busted out the ultrasound machine to look at the diaphragm thickening fraction, and there was no thickening. He could not contract his diaphragm. There was no phrenic nerve signal going to the diaphragm for contraction. So all of his respiratory work was through accessory muscles. There was no thickening of the diaphragm. So, just a quick use case. Obviously, this doesn't happen very often, but if they had called before replacing the catheter, it would have saved money right there. Just the fact that someone knew how to do a diaphragm thickening fraction measurement, because you can easily see if the diaphragm is contracting because it thickens. You're looking at the M mode and you can see the thickness change, and it just wasn't happening. So we easily diagnosed that he had an issue with his diaphragm. So then we begin to monitor that to see. So we left the EDI catheter in and used that as a monitor, essentially to see as activity would slowly return. And in this patient, it did. So whatever was causing the lack of signal, it was something that was just slow to recovery. So it wasn't a severing of the nerve. It was just something was, not allowing the conduction of that signal. But if I recall this patient, it did recover slightly, but I don't know that patient survived ICU.
Was it a post-op cardiotomy patient?
I can't remember. He was even at this time, he had already been ventilated for like 2 months. Like he was that complicated. It's a guy where just like, well, let's try NAVA now. And then it's like, so they wanted to try that to facilitate, more synchronous weaning and this and that, and like responding, proportionally to the patient's effort. And it just, that's when they thought it was a broken catheter at first.
So what you're talking about is prolonged mechanical ventilation and using it to potentially. So one of the things that we're interested in looking at our clinical practice guidelines for the AARC is whether or not these have utility in ventilator liberation from the beginning. So there was an article there was actually a systematic review and meta-analysis published in Chest in 2017 on the use of lung ultrasound to predict weaning outcomes. And then again in 2022, another article that looked at diaphragmatic thickeningness, the diaphragmatic thickening fraction along with the RSBI in order to predict successful liberation from mechanical ventilation. That was a randomized controlled trial that was published in the Journal for Clinical Diagnostics. So I bring those two papers up specifically because in our first recommendation for ventilator liberation, we looked at the use of RSBI alone. But there seems to be a lot of interest now in the combination of RSBI with lung ultrasound for determining successful liberation. And I don't know if what we'll get to, or we are publishing another CPG sometime in the next year. We're in the middle of our literature review for that right now. But I'll be interested to see if lung ultrasound comes back again in our second review, because I think that there is, as you said, from your group, Tom, and obviously others around the world that are interested in it, and I think that there is some argument for the use in liberation from mechanical ventilation.
Hey, Tom, what were you able to use thickening fraction measurements, not in liberation, but in short-term assistance? Like the goal was not liberation at the time. Mm-hmm. The goal was actually vent rest, right? And for whatever that clinical situation was, were you able to utilize that in kind of an acute situation in which you were like, we need more inspiratory pressure here. We are completely under assisting, or we can come down. And you can model the architecture of your breath delivery to meet that need.
Yeah. I think probably one of the use cases that I can recall in terms of being an ideal situation was we were assessing a patient where we were providing more support, but it gets to the point where you're starting to worry about providing so much support if the effort is in fact excessive, maybe potentially resulting in lung injury as well as diaphragm injury. Yeah. So we wanted to quantify how much potential for diaphragm injury is there, because we were sort of at our limit for assistance. You trying to make that decision whether or not you increase sedation or paralyze a patient versus letting it run. Again, right now, we don't know if it's better to let someone run with high effort, and potentially cause lung injury, or we don't know if that's worse than sedating and paralyzing. We know sedating and paralyzing is bad, but the question is which is worse, and we need more randomized trials to determine that. But in this patient, we had already sort of maxed out, like we didn't really want to give more support. And again, we could have put an esophageal balloon catheter, to be honest, but they didn't have one in there. We could have also considered POC measurements. Now, this was before the POC paper. What we could have quantified or estimated excessive dynamic transpulmonary pressure by using a POC maneuver. But instead, we grabbed the diaphragm ultrasound, and the patient's thickening fraction was excessive. It was over 45%. I remember that it was more than 40. I don't remember if it was 45 or 50, but I remember it being on the high end. It was definitely more than 40. I think 35 to 30, 15 to 35 is considered normal. So I remember it was over 40. And at that point, we had to make a clinical decision, like, what do we want to do? Let this patient continue? And I think we had agreed that we would then monitor other things to see if there were changes. And I think FiO2 requirements started going up, et cetera. So it came very clear that we clearly can't, whatever's causing this excessive drive, it likely could have been, poor lung mechanics because we were giving pressures that we weren't comfortable with anymore. So I think the decision for that patient was to sort of have bring them back. These are almost always recovering ARDS patients that have that rebound effect. So it was just one of those things that we knew it was coming, and it sort of just made us feel more comfortable about making that decision, because clearly there was potential for diaphragm injury. There's potential for lung injury. We're at our maximum for supporting the patient. So you have to make a clinical decision. And there's just one more tool, one more value to say, yeah, the thickening fraction is excessive. No matter what we do on the ventilator, we can't reduce it. We tried PEEP titration. We tried inspiratory pressure augmentation, again, to a limit. It came down to us saying, we just need to intervene and give the patient more time to recover.
Yeah. Okay.
Excellent.
But in most patients, it was sort of they've been on the ventilator for a while. Let's assess for diaphragm dysfunction. Yes. So in the case I just gave an example of, it was more like acute, like, are we at our maximum? We can't seem to make this patient calm down. Is the thickening, are we worried about diaphragm and lung injury? Versus in other situations, it's been, is there a diaphragm issue? Like, this patient's not weaning properly. Do they have a normal, can they contract their diaphragm? And that sort of came about because of that issue with that EDI catheter that one time. Kind of like, hey, we should check. All of a sudden, we started getting asked to do it on other patients that were having difficulty weaning because we're like, oh man, are we pushing these patients too hard and their diaphragm can't even contract? So
great conversation as always. Real quick, want to ask one more real quick question while we have about 30 seconds left. Where would one go to learn more about lung ultrasound? Is there a course that you can take? I know that the SCCM provides a course that's very expensive. Anybody know of something that's reasonable?
Yeah, I was going to say CHEST does as well, but also expensive.
Yeah.
I'm not aware of any other courses. Again, how I learned was physician.
Yeah.
Find your physician champion. And so Dr. Sarah Mirza is the one who taught me. But yeah, I'm sure there's courses out there.
Yeah, I would agree with Tyler. Like I provided a bunch of the articles that we mentioned in the talk. I provided a bunch of links earlier. If people are interested in it, definitely check out some of the papers that sort of describe the process. And then when you find that physician champion, because I guarantee there's someone in your ICU, probably a physician who's excited about POCUS, and the next, put your ear to the ground or just talk to them and say, listen, I've read some papers on it. I feel like I have a general understanding of the concept. I would love to assist with you, or to, the next time you do one, can you contact me? Can you call me to come and see it? Then you're going there with a base knowledge. And again, it might not be a full course. Obviously, you're not learning how to do it. But when they're saying, oh, these are A lines, you're like, I know what A lines are. They're like, or if you see things that look like B lines, you can say, are those the B lines that I read about? So again, that pre-knowledge is really helpful. And by doing that, you actually show them that you've already put the initiative in. And then you might be surprised. They might be immediately wanting to teach you how to do it, or be like, here, take over. You'd be surprised how excited physicians get when someone else is as excited about them. But yeah, finding that stakeholder that is super excited about ultrasound is going to help a lot.
Perfect. All right, guys. So as soon as Tom sends me the recording, we'll post it on LinkedIn and on our website. Thanks for everybody who participated. Thanks, Sarah and Tyler, for
thanks for
joining us.
Yeah, thanks for coming on, Tyler.
We really appreciate you guys.
All right. I'm going to end the stream now. Goodbye, everyone.
See you guys.